This is a talk I've never given, and it was fun to make because it made me really think about a lot of the stuff that we've been doing over the last 25 years. And so I'm at Rush, and about half of my practice relates to cartilage repair, joint preservation, things like that, mostly of the knee, but also the shoulder, elbow, but really primarily in the knee. And the great thing about the institution that I work at is that we have the opportunity to collaborate both on the basic science side, biomechanics, and then the clinical side. And what I thought I would do is pick one paradigm or one problem and one solution and share mostly the translational things that we've done over the last couple of years to sort of look at the progress we've made of taking really simple questions, bring them to the laboratory in often a very inexpensive way, in a very time efficient way, and then bring it right back to your practice to make a difference in what you do. And I will just reflect for a moment that my first real grant was a ORAF Career Development Award, and that was in 2001, starting practice in 97. And that made an enormous difference on my career. It was a $25,000 grant. It was from Zimmer, and I'm trying to remember the name of it. If there's anyone here in the ORF who was still there then, it was an award that they funded every year, and it was given to a young investigator. And it was a study that looked at something that Dr. Jacobs looks at, which is the use of hyaluronic acid to coat implants and BMP. It was an animal study that canine study that was one of my first real decent basic science in vivo model studies I had ever done. And it was meaningful because it set the foundation for me to get additional funding, and it provided a lot of credibility when you get an award like that. And it's almost independent of the number, quite frankly, but the fact that the ORAF was behind it was very meaningful. And it wasn't long after that I joined the Shan Circle, which is an amazing opportunity to give to ORAF. And this isn't a pitch to open your pocketbooks, but it was not long after I went into practice that I found out about Shan's, which is a very important organization that has a meeting every year at the Academy. Is it still the same number, 25,000? Is that what it is? Has it changed? So forgive me. Yeah, so basically, as a young person, when you're coming out into practice, where you still have student debt, things of that nature, I basically at that time did deferred giving. So it was part of my estate planning. So yeah, it's a delayed gift, and now my paradigm is changing, to giving while living. But when you're young and you want to participate, there's ways to do that, and all of that pays dividends while you're practicing and towards the end of your career. And it helps these organizations, which, they have over $8 million of funding. They've been a critical part for every specialty, as you see. So it's ironic that Josh asked me to come do this. I'm happy to do it. It's a privilege, but truth be told, this was a initiator for a lot of the work that I've done. And frankly, I'm not sure I'd be here if I didn't have these initial grants and this involvement. So you guys should look into it as you guys finish, especially if you go into academic medicine, look into the Shan Circle as a way to get involved very early. So with that, I want to use osteochondral allograft as a clinical problem that has had and still has lots of unanswered questions that we use to look at various things. So it's sort of a portfolio of here's the question and here's the thing we did and this is what we do now. So you're going to see through the course of your careers lots of clinical problems, and you're going to have many options. You could ignore it or compromise what you do with or for a patient, or you can sort of figure it out. So our paradigm has always been, let's figure it out. And the thing about articular cartilage disease is that it's really a white space in terms of things we don't know. When I came out in practice in 97, the only solution we had for a symptomatic knee with mild arthritis in a young person who wasn't a good arthroplasty candidate was a scope and a debridement. And that was a really incomplete solution. And we've come a long way, but there's so much further we need to go. And to that point, I still fail about 35% of the time. So we take these young patients and we try to either restore a cartilage bone deficit, place a new meniscus, do a realignment procedure, and so forth. We still fail more than a third of the time with continued unacceptable pain and dysfunction. They come to repeat arthroscopy and debridements. They undergo revision transplantation, and if they come to arthroplasty, those patients behave differently after joint replacement compared to their counterparts who just have osteoarthritis who never underwent cartilage transplantation. So it's a really challenging problem, and some of these patients just have continued pain no matter what we do. So the clinical problem that I'm going to talk about for a solution is how to best treat articular cartilage defects. And we have all of these different options available to us. And those are the current frequencies. You can debride, you can do a marrow stimulation, we can use some type of surface cartilage graft. an osteochondral autograft, which is basically a plug of bone from one part of the joint, taking it to another, like a sort of like a hair transplant, cell-based transplantation, or MACI as they call it now, and then finally osteochondral allograft. So I'm going to just talk about that. I could possibly generalize this to any of these other procedures, but let's just focus on one, and I'll just give you some examples, and maybe this will stimulate some of you who are interested in ongoing research to come up with some ideas of your own. The best place to get it is in the clinic. You know, when you see the problems that your attendings and mentors are having in the clinic, identify those and figure out a way to get it done, take it to the lab, take it to an animal, and find a solution that you can generally bring back to the clinic in short order. So when I first came on practice, we really didn't have any algorithms to treat cartilage, and we just basically did it on defect size. And it was pretty rudimentary. It wasn't even scientific. It was just, well, the small ones will debride them, and the big ones will put an osteochondral allograft on, but we're not really sure about all the other independent variables. And the decision making has gotten much more granular over the years, where it's not a cookbook approach, but it's still much better than we used to be in terms of compartmentalizing how to treat cartilage and bone problems, address all the comorbidities, look at patient-specific factors, and so forth. So that's the subject of another talk, and I'm not going to go into that, but just want to help you understand the complexity of the problem. But one of the solutions is an osteochondral allograft. So that's a graft of bone and cartilage that we take from a living donor. Someone who donates heart, liver, lungs. They also donate cartilage, and it can be used for the trochlea. It can be used for the patella. It can be used for large defects. This is a NHL player who had a very large defect, who was unable to play, ended up having a full graft of the trochlea, as you see here, and was able to actually get back to play. So it's probably one of the most predictable solutions we have for localized cartilage loss. So how do we get better? So this is what I'm asking you to consider when you go to the office and see patients. We can do it by clinical experience, which actually, while it's level 5, I'd say level 5 data is pretty important. You're not coming out with a whole lot of level 5 right now, but add 20, 25 years, 30 years down the road, you have lots of level 5 data, and that's also important. I would never discount that. But the things that are objective is basic and clinical science research, translational research, like I'm implying, the opportunity to think outside the box for a solution, having the privilege of collaborating with other people, and then learning from our mistakes. To me, I'm much more interested in publishing our failures than I am our successes, because that actually gets a little bit mundane after a while. But looking why we fail and all the independent variables that are associated with that is far more interesting at the end of the day. So this is what an osteochondral allograft failure might look like. It may look poor on MRI. You see a deep graft here, some breakdown, and it may be poor when we look at it in an open setting or an arthroscopic setting in terms of collapse, delamination, or failure. So I think it's best, before I go into it, just to show you a brief video so you know what the procedure is. So this is a arthroscopic video. That's a medial femoral condyle with a delamination that had undergone one prior debridement, which is a competent solution for this to help alleviate symptoms. Patient continued to have pain. That's an allograft that comes in, it's cold preserved at 4 degrees centigrade. It's thawed in the operating room, meaning it's gradually rewarmed, not thawed in a sense that it's frozen to non-frozen, but gradually rewarmed. It is cut down. There's a chance for trauma to the graft when we cut it. We ream it with a reamer. In the past, this was just reused instrumentation that would wear over time. Sometimes we see metal debris. Sometimes we see graft failure with delamination and cell death. We'd see that at time 0 when we looked at these in the laboratory. So all these things became really interesting to us. The cartilage doesn't have a whole lot of immunogenicity. We say it's privileged, but the bone is where all the action's at, and that's where most of the immune response is, probably from marrow elements. So we think we'd like to have the least amount of bone necessary to keep the graft alive. We learned from our tumor colleagues that bulk grafts maybe have challenges because there's so much bone, and they may fail over time. Then we might add some voodoo, like some biologics, that was bone marrow concentrate, and then we put the graft into place, and then we may tap it into place with a mallet and an impactor, right? These are all the things that go on. So you should get your mind going to say, well, look, how does each of those steps matter? And if we have hot spots or failure points, how can we improve upon that? So one of the first questions we asked was, how long can you actually store the graft? Because this is a hot commodity. There's a shortage of grafts. We don't have an unlimited supply, and they're left at 4 degrees centigrade, but you can't do it forever. And one of the first studies we did is in the laboratory, we determined that after 28 days of cold preservation, there's a precipitous drop in sulfate incorporation and an increase in cell death. So we defined the time frame that a tissue bank can keep this cold, which is about 28 days. After that time frame, the grafts would expire. Today, many years later, that was 2004, 28 days is still the time frame for most tissue banks. How do we maximize the fitness when we take it out of the package? It comes at 4 degrees centigrade. You just plop it in room temperature water. You put it in warm saline, which unfortunately happens when the staff isn't paying attention, thinking it's frozen. What do? What we showed is that if you just rewarm it from 4 degrees to 25 degrees, then to 37 degrees, that preserves cell viability more than just bringing it abruptly up to 37 degrees. It was a really simple question, but very easy to answer in the laboratory with collaborators. When we instrument it and you have heat and high torque, how do you minimize cell death during instrumentation? Well, one thing was we learned that the instrumentation gets dull over time, so we developed disposable instrumentation. Well, economically, clearly not as responsible as reusable. We showed that cell death actually decreases if you have fresh instrumentation. It makes the operation far more precise. We also showed that what we used to do is irrigate the graft when we would core it out. When I showed you when we were irrigating it with the reamer, now we actually submerge the graft. We showed that the submerged graft in water when you're coring it out has about 72% viability. But what we used to do is take the graft, put it on the table, and just ream it and put some irrigation on it. That was about 61% viability. So that's something we didn't expect to find. We just thought it was okay to spray it down with saline while you're doing it. What about graft thickness? How thick can we go? Well, what we learned is that most of the immunogenicity is in the subchondral bone. So the less subchondral bone, the less immunogenicity, and the less chance for failure. And that's been borne out in the literature that thicker grafts don't survive as well as thinner grafts. So we now go to about 6 or 7 millimeters, and it used to be 10 millimeters or more. How do we reduce the immunogenicity further? Well, some others had looked at the effects of pulse lavage. Just take what you use in trauma and so forth and lavage the graft to try to get the marrow elements out of there. And we and others show that you can get pretty deep in terms of penetration in the graft to get rid of the marrow elements, but we wanted to go one step further. So this is a device that's been used in arthroplasty. And we said, what if you deep clean the graft with carbon dioxide? And what we showed is that that will further remove the marrow elements and potentially reduce immunogenicity. We have not studied it clinically yet. That's the next step. But we know objectively there are fewer cellular elements if you deep clean the graft like this. And then we learned that there might be ways to improve graft integration. So we were noticing that at CT scan, these grafts had cystic changes, and we became interested in using orthobiologics. So what we did is we said, what happens if you take bone marrow concentrate after you deep clean the graft? So we deep clean the graft, and then we add bone marrow concentrate. And what we showed is that by CT scan at 6 months, those who got bone marrow concentrate had reduced large cyst formation and a reduction in subsequent surgeries. So a really simple question, what happens to those who get it? What happens to those who don't get it? And does anything change radiographically? And does anything happen clinically? And we showed this had a positive impact. And then we also want to ask the question, well, how much more orthobiologic can you actually add? This is a former fellow of mine, Seth Sherman, who recently completed a study, and we did this in collaboration. We said, look, if you don't prepare it or deep clean it, versus when you do that, does the porosity change so you can get more bone marrow concentrate into the graft? And visually, it's far more satisfying when you see that versus the one on the left where the bone marrow concentrate kind of sits on top of the graft. But then when we deep cleaned it, it added to the porosity. We said, can you actually quantify that? And what Seth did is he showed that we had a significant weight reduction. If you did deep irrigation, got all the moisture out of it, the graft was lighter. What happened above and beyond that was that the amount of bone marrow concentrate or agent that you could add as an orthobiologic increased significantly if you created more voids within the graft. So we knew it's beneficial. We just said, how do you get more of it? And we basically showed in the lab that deep cleaning the graft would allow more to penetrate the graft. Okay, so what about graft impaction? What we used to do is this. We just set the graft in and we just start banging on it until it was flush to the surface, right? You spend all this time, money, and energy to do this, and you start hitting the graft, there's got to be some consequences. Well, there are consequences. And we had 3 studies that showed different things. The frequency, can you put a biologic in to reduce cytokine production? What about the intensity? All of these questions we asked, and we said, well, how can you change the instrumentation to make it easier to insert? And maybe we can even get to the point where you don't have to hit it at all. You can just press it in with your thumb. So the bottom line is, it has kind of face validity to say if you hit the graft, probably not a good thing to do. So we've pretty much gotten away from that. And at this point, what we do is we just dilate it just enough that the graft will press fit, but we try never to hit the graft. And to reposition the graft, we just did this little trick. We said, let's just put a suture under it. And if it has to be moved again, you just pull the suture, tug on it, spin the graft around. When you're all done, you just pull that suture out. So technique evolution has happened because of things that we've learned in the laboratory. And in the past, all we ever did, thousands of these procedures where people are just hitting the graft. And we and others have pretty much shown that that leads to downstream cell death and apoptosis. Okay, what if you drop the graft on the floor? Okay, basic question. Never happens, right? I had my 13-year-old son in the operating room, scrubs like hanging off his legs down to his elbows, and he's watching, and it's a Saturday morning because the graft was going to expire, and literally a person, I don't want to say a resident, but it might have been a resident, had a retractor in there, and the retractor slipped out, flipped the graft off the table, and landed on the floor. Okay, what do you do? And this is what he says to me. He goes, "Dad, was that supposed to happen?" I mean, and he was kind of serious. And so what do you do in that situation? Well, in that setting, we actually had more graft material that we could use, but we became interested in how do you solve that problem without killing the graft, right? Maybe you won't have enough graft available. So we looked at a couple of different means to sterilize the graft. We borrowed from other literature and allograft research, and we found that if you use 0.002% chlorhexidine, 1 liter of it, that will sterilize the graft and not compromise cell viability. Super simple question. 3 weeks ago, this happened to a colleague of mine. They literally pulled the paper. This week, a nurse came up and said, look, we now have a protocol. Can you just verify that this reads correctly on how to do this? How do you dilute it? How much do you put in? How can we follow that protocol? Like, that's a meaningful thing. You hope it never happens, but at least you have a tool to resolve it that you can stand behind if it does happen. Okay, then we started to ask the question, are we actually doing anything biochemically? And can we change biomarker profiles? And does that track with how patients do clinically? And in fact, this is something that we recently completed. We said, let's just aspirate all these patients and see how post-operatively as those aspirates change with biomarkers. And what we showed is that interleukin-1 at 2 weeks post-op is indicative of a improved KOOS subscore at 6 months. Said another way, biomarkers measured across the course of their post-op course, as those tracked in a positive direction, so did their clinical outcomes. Really basic question. In osteoarthritis and inflammation, these cytokines go up. Can we actually make them go down by improving the condition of their cartilage? And the answer in this instance was yes. Okay, big problem. We don't have enough grafts to go around. Okay, so these tissue banks are looking for means to improve graft availability and deliver them to us. And if we start getting more specific and saying, well, I want a graft that's this size for this reason, there's even a further shortage of availability issues. So we basically set out to say, look, can you take a medial graft and put it on the lateral side, or a lateral and put it on the medial? And the answer was yes, up to certain sizes. What about overlapping versus large grafts? There's some new surgical techniques that take a really large graft. We said, look, you can't always get a large graft. Is it the same thing or better to take 2 small grafts and tile them together? And can you still recreate the topography? And through FEA and a computer simulated model, we showed that, yeah, you can still recreate the topography. You don't have to have a huge graft. You can have 2 small grafts and put them next to each other, and they do just as well. What about guides that might help us with instrumentation, this PSI or patient-specific instrumentation? Can we open up and be more liberal with the grafts we take if the instrumentation increases? This is still really early on, but those are some of the questions that we were asking. Okay, so that's sort of all the preclinical stuff that led to some really, I think, simple questions, trying to identify solutions. As I say, not very expensive. Most of those studies were done in less than 6 months. And they led to, in almost every instance, a meaningful change, not just what we do at our institution, but how others think about the problem. And then the obligation, if you're going to get into this, is to track things clinically. And this is a relatively rare problem. So when I came out in practice, the goal was to capture every single patient, because there's just not a lot of them. And we started out with a registry, and just a smattering, just an osteochondral allograft, of the kinds of things that we've been able to look at and publish. And I don't take isolated credit for this in any meaningful way. While I have the patients, this takes an army to track these patients. And it's not just a database that does it. You have to have full-time people, research assistants, that pay attention to this stuff to capture these patients from time zero. And then you have to have programming through your EMR to actually reach out to these patients, and very good compliance to get it done. But these are some of the papers that we've published in all areas related to osteochondral allografts and clinical outcomes. So what I'll do is I'll just go over a couple. Just some of the important ones. This is a study where we looked at medium to longer term follow-up, minimum 5 years, 7.5 years mean, just looking at improvements in PROs. And basically, we looked at survivorship. And this is what patients want to know. How long is this allograft going to stay in my knee before it fails? We showed survivorship of 86% at 5 years and 82% at 10 years. That's useful to know if a patient wants to know how long is this graft going to last, at least how I will do clinically over time. What about return to sport? Can you actually get someone back to sport after this? Yes, you can. Someone who has an isolated cartilage defect, treated with an osteochondral allograft, return to sport is in the range of 75 to 88%. What about age and gender? We looked at that aspect. We found that when females fail, they tend to fail earlier, less than 40. When males fail, they tend to fail later, greater than 40. We also looked at comparisons and outcomes, and while we saw no differences overall in complications, reoperations, and failures, lower Q scores were seen in those less than 40, and that might have something to do with that's just a higher demand population, okay? What about size? Size does matter, and the reason we determine that is because what we learned is that those who have small femoral condyles tend to have more symptoms because it's a larger area of defective cartilage. Those with larger femoral condyles, with the defect size being the same, tend to have better pre-op scores than those who have smaller femoral condyles. So the contribution of normal cartilage to abnormal cartilage matters. That's why size matters, not the absolute size of the defect itself. So those are things that we learned. We can talk to a patient and say, look, if we get a little more data, we'll start to predict, do you have a high likelihood of success, intermediate, or a low likelihood of success if you go through this? Does it work in adolescents with open growth plates? That was just another subset because we had this amazing registry. And the answer was yes, but they didn't do as well as their adult counterparts. So we can do this in kids with open growth plates, but they did not fare as well clinically in our PROs. What about if they had prior treatment? This is a subject in my world to say, look, they've had a previous debridement, they had a previous marrow stimulation, they had a previous cell transplant. Can you do an osteochondral allograft and still expect a good outcome? And the answer was yes. In this setting, you can expect as good an outcome compared to a cohort who's never had a transplant before. And then finally, we spent a lot of time on saying, look, you can't just look at these patients in a box and say they have a cartilage problem, because many of them are missing their meniscus or some of them are malaligned. So how do those people do? Can you still get good results? And in general, meniscal allografts or meniscal transplants can return even high-level people back to sport about 75 to 85% of the time. So we said, how do they do if you had a graft? And those patients actually do well. If you correct all the comorbidities, meaning meniscus deficiency and an osteochondral allograft, the outcome scores look the same as patients who have an isolated meniscal transplant. If you don't correct that comorbidity, they look abysmal. So we now know you can't ignore this stuff. If you're going to get into this world and treat these patients, you got to kind of fix everything at the same time or in a staged fashion. Same thing, osteotomy. Osteotomy is a great operation, right? If you go to Europe, the same patient here who gets a unicompartmental knee replacement, they get an osteotomy. We've shown, and others have shown, that you can improve patient-reported outcomes, and you can actually return athletes back to sport with an osteotomy with unicompartmental arthritis. Can you revise it? But added to this, when we looked at our patients who get what we call the triple threat, they get an osteotomy, meniscus transplant, and an osteochondral allograft. Those patients fare just as well as an isolated osteochondral allograft. So just showing you, if you have a foundation of data, you can actually help educate your patients to say what you can expect if you decide to undergo treatment. Can you revise it and have a successful outcome? Yeah, as I told you, 35% of these patients may fail over time, and we see a lot of failures in the first 5 years. And we saw that patients can be revised and have survivorship the second time around as well as the first time, as long as you correct all their comorbidities. But we still have a lot of work to do. This is still my hardest patient. This is a patient who had a cartilage graft, still has pain. This is what a graft looks like at second look at 1 year. It looks pretty perfect. The surrounding area doesn't look great, but that we replaced probably about 80, 90% of it. The CT scan showed perfect integration of the graft, but the patient has no change in clinical outcome. Okay, so to this day, we have a lot of these patients. I have no idea whether this patient didn't get a successful outcome, and maybe it's just something we don't understand. And I think all of us have those patients in our practice where they come in and you really have you kind of have this feeling you're not going to be able to help them, and you can do A, B, C, and D. At the end of the day, they're no better. This still remains our most challenging problem. So how do we optimize this? So this is, you take all these things and you think about it, can these actually be inputs so that we can be a little bit better at our jobs and have a more predictable outcome? And I think the focus, and this is for those of you in this room, this is where I think it's going to become particularly relevant, right? How do we improve our future decision making? And you probably could predict what I was going to say. It's going to be in the area of AI, right? We have so much data that you could probably create a generative process that will help us make decisions for our patients. So this is just something that we're becoming interested in, because now we're going to say, how do we use all this data, make a better decision with our patients, and give them some predictor to say, this is what you can expect if you undergo this treatment. So this is just an example, a patient-specific analysis. What's their propensity to succeed or have a good outcome? Standard patient, 18-year-old male, BMI of 28, doesn't smoke, recreational athlete, had 1 cartilage procedure, it's not workers' compensation, has 8 months duration of pain, doesn't have effusions, had a traumatic injury, had a grade 4 lesion exposed bone. It was 25 by 25 millimeters in size, and it was a lateral femoral condyle, right? That's just a subset of things that you might think about. How does that patient do if you give him an osteochondral allograft? How does that patient do if you give him an ACI or a cell transplant? Those are the kinds of things I hope you guys, I'm going to be long done with my career when you guys can come up with an algorithm that'll help. When a patient walks in the office, they'll have a survey they fill out. You'll put that in, and a minute and a half later, maybe 10 seconds later, it's going to spit out what the best treatment is for that patient. So I'm not one of those people that believe that AI is going to replace us, but certainly a person who uses AI is likely to play an important role in our near-term future. So what are the key takeaways? Ask questions, get lots of experience. That's level 5 data, right? People kind of, they smell as level 5's experience, do a level 1 study, prospective, double randomized trial. That's the only way you're going to know the answer. I completely disagree. I can point out study after study. There's been a level 1 study that doesn't push us any further. They're just hard to do. That doesn't necessarily mean that guides our direction in clinical practice. Perfect your technique. Do translational research, right? I think that's incredibly important. I just gave you one problem, one solution that had an abundance of questions. And those are really stupid, simple questions, right? How do you prevent cell death? How do you warm it up? How do you open the package? How deep should you go with the graft? Those are basic questions that you can continue to ask and get those answers if you have the right people around you. And I think what's really important is, you got to take a look at your outcomes. And I would say once you're getting good at what you're doing, start focusing on your failures and see how we can actually do better for our patients. So thank you for the opportunity to present, and it's really enjoyable to be here with you all, and great job on your talks.